Okay, thank you very much. So I'm going to follow on, hopefully, quite nicely from Ed, and you might even recognise a picture or two because I can see the papers. I'm going to think a bit more about real-world studies, and I'm going to think a bit about why we need them. And I'm going to tell you about something called the class act study, which was not UV, it was actually filters, but I want to show you some of the lessons that we learned from carrying out that study. So I guess this is sort of, a recap from what we've heard over the past couple of days, but why are we doing this? Ultimately, we're doing this to reduce transmission of infectious disease. We're not doing this for any other reason, as far as I am aware. But of course, which diseases? Are we doing all of the communicable respiratory diseases? Are we doing all of our hospital-acquired infections? Which environments are we doing that in? Do we want it to be absolutely everywhere? Do we want to focus on very specific environments, hospitals, care facilities, GP surgeries, etc.? And which transmission routes? We've very much focused on the air, but also we've touched on surfaces. And we did hear earlier in the week that we can use this in water disinfection. So there are all sorts of other potential things in there as well. Whatever it is we're doing, I think, as we've heard already quite a lot today, we need a certain amount of evidence for that particular challenge. And that's not just generic evidence, it needs to be evidence that relates to a scenario that can go in, or can be translated into that scenario. And that evidence is going to be needed for somebody to make a decision to say, okay, I think this is the right thing to buy, we're going to go and put this in, we're going to invest our money, and we're going to keep this going. So, kind of a recap. So where we are, we've got a lot of data out there. We've got, I mean, if you look at what's happened over the past 3 or 4 years, it's a huge amount of research going on, an amazing amount, far faster than I think we've ever seen with pretty much any other technologies. And we know something about its efficacy against pathogens in water, in air, on surfaces, at lab scale. And we know quite a lot, both from lab scale, from animals, and from human studies around eye and skin safety. And that, although we can still see there's some gaps in there, that body of evidence is saying, okay, this is worth us exploring. And we can also see from room scale stuff, chambers, and some of the sort of smaller real-world type studies, that we see that rapid reduction in bioburden, but we also see that secondary chemistry, the ozone, the secondary chemistry effects, and we know there's a risk trade-off in there. But when it comes to what does this actually mean in terms of human health, we're relying on models. So we're relying on models to translate this into human health benefits in terms of reducing infectious disease. We're relying on models as well in terms of where there might be potential harms, particularly from the chemistry side. So we've got to think, how do we get this into a real-world health effect? And it comes down to these full-scale human studies. So if we think about where we are, you can write some frameworks for thinking about quantifying health effects. These are quite well known. The one on the right, your right, is often what's called a quantitative microbial risk assessment type framework, where we think about what's our exposure or incidence of a particular pathogen. We use a dose-response equation, a different dose-response. When I'm talking about dose-response, I mean the dose of the pathogen and the human response to that pathogen, as opposed to the dose of the UV to that pathogen. I suddenly realised that this is 2 different doses. But then we have your risk of infection, but then we also have, following infection, you don't necessarily show disease. Some people get infected and just get better, we don't notice it. Some people go on to have disease, and that goes on to have a health impact. And that health impact might be very short-lived, might be something you're ill for a few days, no long-term consequences, or it might be something that is long-term disabling or kills you. And you might see some words in there, YLL and YDL. Those are years of life lost and years living with a disability, and those can be added up to make something called a DALY, and they are often used to do long population scale health impacts. The left, equivalent, which is for pollutants. So you can see actually for something like RUV, on the right we can do disease transmission, on the left we can do something that's more akin to the chemistry. But where we are at the moment, we're pretty much playing in this top space. So we're thinking, and that's inevitable, that's where we start with any technology, but we're thinking very much about the bioburden or the pollutants in the air. We've got to now move it to where we go to humans. Okay, I mentioned the word dose response already, so remember this is not UV dose, this is now how much pathogen somebody's exposed to. And just like with the UV dose, I guess, there is a dose response. So when you are exposed to a particular amount of pathogen, we see people respond. You see a certain number of people will get infected. And usually we have something, it's a probabilistic thing, so some people will become infected at a much lower level, others it's a much higher level. And we can take data from cohorts, we can take data from animal studies, sometimes from toxicology type studies, and work out these dose response curves. They're hard to do, very, very hard to do. We do need some of this. But actually, what you end up with is quite a typical curve. They will look a little bit different for different diseases, but they look something like this. And it allows you to think about how much of this matters. Okay, so what I've shown on there at the moment is the 50% tolerances. It's often called the ID50, and 50% of the population, when exposed to that amount of pathogen, would likely be infected. Okay, but think about where we might move. Okay, so here's our 50% dose. If you do something in the environment, let's say you put your UV in, and it quite substantially reduces that dose. This is a log on the bottom, but I've deliberately not put numbers on it so you can't hold me to anything. Okay, let's say we reduce it quite a bit. Hey, this is good. Look, the human response has dropped right down. So let's say we've halved our bioburden in the environment. We've quite substantially reduced the infection risk there. But what happens if we're up here? Okay, if we're up here and our UV might halve our bioburden, but it doesn't do very much because we're right at the top of the curve. And that's one of the challenges. So we can measure bioburden, we can say, hey look, 50% reduction, 80% reduction, 90% reduction. But how much does it actually translate to in terms of reduction in infection? And we don't know because it depends where you are on that curve. Hopefully you're in the middle or the bottom. But hopefully in the middle you get the biggest bang for your bucks in the middle. So we need data about people. Okay, so how do we put humans in the loop? We need real measurements which relate to people and studies, and we need those in some form of real-world type settings. So real-world studies often are in homes, schools, or places, hospitals, etc. We measure environment, we measure health and well-being, we measure all of these things together, and we come up with an answer. It sounds really straightforward. It's actually not straightforward in the slightest. You have a lot of things happening at the same time, particularly with things like respiratory viruses. There's a lot of people interacting. There's maybe different viruses circulating, different variants of the same virus circulating. You need a lot of data to prove this. You need to think about the types of studies. There's all kinds of different epidemiological studies out there. The two most common, I think, in terms of these type of showing something happens, one is called a case control study, where you start with the people who have the thing that you're trying to study and find another group of people who didn't have it and compare the two. With things, for example, like COVID, that's really hard now because nearly everybody's had it, you can't find those people. Where we might be more likely to go is an intervention trial, where you deliberately say we're going to set up some groups of people, we go forwards and we think about what happens with a group that has this versus a group that doesn't somewhere. So if you think about how you design these sorts of trials, first of all you have to think what you're trying to measure. Are we actually measuring cases of a particular infection? Are we measuring cases of COVID or TB? And if we are, how are we measuring it? Are we measuring it based on a lab test? Are we measuring it based on a symptom? Or are we actually not going to measure the actual infection? Are we going to measure something different, like a proxy? So lots of studies use proxies. they might use illness absence from work, and they might get as far, or school, and they might get as far as saying it's because of respiratory, but not go as far as saying what disease it is. Are we going to measure something like GP visits, or ambulance call-outs, or A&E visits, or hospital attendances? Or could we measure something around symptoms? So there are studies out there that have very successfully measured people's respiratory symptoms, for example, around sick building syndrome. Is that actually a self-reported symptom, or is it something that you go and measure? And the same we're thinking around heart. If we're thinking about the effects around air pollutants, do we measure, what's our proxy for that? How do we actually measure it? Are we measuring something like asthma? Are we measuring somebody reporting symptoms? All of these have to be built into a study, and which decision you make, which one you go for, changes what you can draw out of that study. You know, your gold standard might be the top one, actually measuring a particular infection. But sometimes that's just too hard to do. You don't have the resource or the data or the ability to do it. We've got to think about who's in this study. If we've got people, whether they are the people with a disease or the people who are susceptible to that disease, how do we think about them? We could have a single group of people who maybe are exposed to a particular set of conditions and then exposed to a different set of conditions at some other time. But then you've got a time factor in there. And it's quite hard to deal with those single groups. Works quite well for things like productivity studies. You ask somebody to do a test and you ask the same group to do the same test under a different set of conditions. But it doesn't work so well for disease, because disease happens over longer timescales. And you might get different consequences with different groups of people, different ages, genders, etc. So then we need to think, well, do we need two groups of people, comparable populations? And again, any study has to think about this, because if I show my UV has an effect on primary school children and I compare it to a bunch of adults in the workplace, then they're not comparable at all. So we have to think about their ages, their genders, the underlying conditions that might be in their socioeconomic status, health conditions that might be playing into this. We also maybe have to think about there are different groups of people in the same place. So if it's a workplace or a school, it is both a school and a workplace at the same time. Ditto a hospital, you have patients and healthcare workers in there. And then do we actually measure individuals? Do we recruit individuals into a study and track them and their symptoms? Or do we recruit as a cluster? So for example, in the school, it might be you're measuring the number of illnesses in the whole school as opposed to measuring individuals. How you collect that data matters. Any one of these trials, whatever you do, has a whole bunch of co-founders in there. So as well as trying to say, okay, we've got our intervention that happens, we've also got a whole other set of things that might be going on at the same time and might be different in different settings. So that's the building and ventilation, it's temperature, humidity. Might be weather and climate. If we're doing one on the east coast of the US versus the west coast, we've got some different conditions in that. Then we might have underlying infection things. So during COVID, the underlying infection rates may well have a really significant influence on whether an outbreak is likely in a setting or not. And if that underlying infection rates are different in different geographical areas, you've got a different thing going on. Similarly, in a hospital, if you've got infection control measures in different groups, different parts of the hospital, that might be a co-founder for you. And then how people behave. People behave differently and intervene with devices differently, and we'll talk a little bit about that in a minute. Okay, so I'm going to quickly touch on, first of all, the human to animal studies, which Ed has already introduced. These actually have a lot of advantages, because we're not now thinking, we've taken out one of the big variables in behaviours because we've replaced them with guinea pigs or mice or hamsters. So it's well controlled. We've dealt with some of those co-founders. We can also deal with how the exposure happens. The animals only have an airborne exposure. They don't have an exposure by touching fomites in the ward or other things. And we also have that ability to directly relate via molecular methods the actual which animals were infected affected by which people. And that allows, again, some really interesting insights. There are questions though. I think the biggest one is, can we assume that that disease in the animal is going to be the same as for humans? And I think for some we can, for others we have to be a little bit careful, because we know then that the dose response or the quanta calculations and things are a human to animal calculation as opposed to human to human. But it's still a very good measure. You also, as Ed has indicated, we need specialist facilities, we need licenses to work with animals. So it's not a straightforward study to do. And we also need to think about design for onward transmission, which again goes back to why TB is great, because the onward transmission happens relatively slowly, whereas many viruses, the onward transmission will happen quickly, and you can't necessarily work out whether your cases are due to your index case or due to your secondary cases further down the line. Again, I can recognise some pictures here, I've got an extra one. So to my knowledge, there are 3 of these studies, or 3 groups of these studies that have been carried out. The original studies of Riley and Wells, which Ed has mentioned already. Studies that were carried out in Peru in the early 2000s by Rod Escom and colleagues, and I was lucky to have a little bit of involvement in that. Very similar principle, from the TB ward, passes through, you can see 3 guinea pig houses on the roof of that hospital, and one of the wards had UV lights on in there, passed through those guinea pigs on alternate days. And then, as Ed has already introduced, the South Africa air facility. So you need these facilities to be set up in order to do such experiments. But they do show, from UV experiments, they do show good results. Both, all 3 of them have, and particularly the 2 most recent, the one in Peru, the one in South Africa, have shown us quantitatively that reduction in transmission due to the UV. Both were similar, 70 to 80% reduction. And both of them also allow us to understand the variability, to calculate things like quanta, to have a fully characterised system. So those human to animal studies are incredibly valuable and really important, and I would agree with Ed that actually trying to get some 222 data from one of those would be a real step forward for us. But what if we want to go true real world? Where do we go? And there are all sorts of places. I'm going to touch on schools because these are quite a popular setting for these. Why do people pick schools? Because schools are a really consistent environment. It's the same people, same children, they're day in, day out, same groups of people. We know who's there, mostly, not always, but it's reasonably well defined. And it's a place where infections are common, there is concern around transmission, there's a worry that they're going to community hubs with transmission. So it is a place where if we can intervene, and of course if we saw during the pandemic the real harms that come from closing schools. And I think we're only really seeing that now, how big an impact that's had on children's education. If you can keep a school open during a really significant disease outbreak, then we should do everything we can to do so. But there are a lot of challenges. So the participants are children. They can't consent. Their parents have to consent. Their parents may well not understand very much. There are also challenges around exposure, and I'll come to that in a minute. Lots of schools have many, many other things to deal with. To be honest, being in a research study is at the bottom of their list. And I guess one of the biggest challenges is the children that go to schools often go and interact in lots of other places too. So it's very hard to separate out where transmission happens. Okay, but there is a history of this, going back to the really early days. Studies that Wells carried out, late 1930s, early 40s. He worked with 2 European colleagues worked with primary schools that had lower years, primary years, and then upper classes, older children. And they put UV into some of the classes, particularly the younger children classes, but not in the older children classes. They tracked data over 4 years, plus they had 5 years of prior data, because there was lots of other stuff. So that's another thing to bear in mind in these studies. These studies are not going to happen before the next ICFUST. Okay? These take time. But they tracked all sorts of different diseases, particularly measles, chickenpox and mumps. And then there was a second study carried out in New York in the mid-1940s, again, taking 3 schools with different, they were all mechanically ventilated. One had GUV put throughout, one partially, and one was a control study. And they again tracked measles. But they noted that children in these schools interacted more, particularly by travelling on buses. The pictures on the right are from Wells' original studies. So if we look at what happened, and this is just these are perhaps the most interesting graphs from Wells' paper on this. 2 schools, both show the same trend, that in the primary classes, the attack rate of that measles, there was a big measles outbreak in 1941, the attack rate considerably lower in those irradiated rooms, it's around about 15%, whereas in the unirradiated rooms, it's up in the 50%. Okay, so they saw quite a significant difference. The other study, slightly more complicated, they did see some difference, but not overall. So the overall infection rate was no different, but what you saw, the top one, is the irradiated classroom. What you see is a longer, slower, more spread out transmission, compared to this one is the unirradiated classrooms, and this one has half the classrooms irradiated. So something's going on, it modified it didn't change the overall rate, but it did spread it out. And that's actually really consistent with theoretical models around epidemics and how airborne interventions might be. Okay, let's go to present day then. So I'll tell you a little bit about our study, which is a contact study. So this was a pandemic study. We had 31 primary schools rooted in the study in the Bradford area, UK. That's over 330 classrooms, and it's about 13,000 children in total. So we had 11 schools in our control group. We had 10 schools which were given portable HEPA filters, these things here, and then we had 10 which were in a UV group, and I'll explain the UV group in a minute. Every classroom we measured air quality, so we measured CO2, temperature, humidity and PM. And then we couldn't measure COVID, so we had to measure illness absence, and we know that the majority of it was due to COVID because it was right in the middle of the pandemic. And importantly, we also did some work around the practicalities of this. Okay, so this is called a cluster study. The unit of the measure is the school. All of our schools were naturally ventilated, they were all a similar size. We excluded the youngest children, and we took a bunch of schools and balanced them across different geographical areas within the city region, the demographics, the architecture. And our schools covered from probably some of the wealthiest schools in the UK down to many that were some of the most deprived schools that you can find in the UK. We did our data analysis from September 2021, so we installed everything over the summer of 2021, and we collected data from September, and we carried on collecting data, but we stopped analysis March 2022, and that was because that was the point where the government changed all the guidance, and basically everything went out the window around pandemic controls. So we had to say we couldn't do data after that. How did we select this? At the beginning of the study, we were asked to do a power calculation. That's a real nightmare to do. We found a study from 1954, which had tried to look at this in schools in London, and they were estimating sort of in the 10 to 20% transmission reduction range. So we kind of went, okay, conservative estimate. I did a power calculations and estimated that we needed 92 classrooms per group of the study, so 3 groups of the study. And then for a good measure, we increased it a bit. Partly because we've got very diverse schools, and some of these schools were small, and we also thought some might drop out. We put in HEPA interventions, so size to give about an additional 3 to 6 air changes an hour per room. Typically it was 3 units per room. And then UV, we intended to put in upper room. That was the first thing. Upper room UV, which would have been an equivalent of about 20 air changes an hour. Straight away, at least half the classrooms had ceilings were too low or stuff hanging around and that you just could not put this in. So those ones we had to put in closed UV units in. And then we hit some other issues with the GUV, which I will come to in another slide in a second. But just to say quickly on where the outcomes were, we could see that the filters removed the particulates. We've only been able to do the analysis with the filters so far, but we do see a reduction in illness, and we are trying to publish that study at the moment. But back to where the UV stuff is, we hit a legislation issue around the fact that this comes under control of artificial optical radiation at work regulations, but those cover workplaces and not pupils. And we had an issue raised that what's the exposure of children and what's appropriate for children. And after a bit of debate on this, we were not able to switch them on. We couldn't get approval to switch them on. We went through quite a long process. We convened an expert panel. We carried out a lot of measurements to show that the systems were safe. We then reconvened that panel. The decision of that panel was there was no evidence to suggest a different exposure for pupils. So they recommended that we did some in-situ testing, but that would then be too late for the study. And we hope if we can get some further funding, we'll revisit it. But it just shows that the best laid plans got kiboshed by something that sat in the regulatory space and took us quite a long time to work through that, which then affected the study. Secondly, how hard can actually running one of these studies be? And we did quite a lot of data collection. We've analysed it, something called the Capability, Opportunity, Motivation and Behaviour, the COMBI model, which is all about how we think about behaviours and environments. So, capability. Do we have the knowledge, skills, abilities to engage in it? First of all, teachers are not aware of the importance of ventilation, let alone why they need an air cleaner. And this is in the middle of a pandemic. Because we are all in a bubble. We're so used to thinking about this, but we forget that many people are not. And if we're going to engage school, we're engaging people who know nothing about what we do. Not all of the staff were able to or knew how to maintain clean air filters, keep on the common. And then the children like to play with them. Every one of our air filters has got Lego stuck inside it. It goes round and round and upwards. So there's things that happen with those environments that we didn't necessarily intend. From an opportunity perspective, external factors, one of the biggest challenges we had first of all was power. Classrooms don't have plug sockets in them, not anywhere near enough plug sockets. We had to rewire some classrooms. That's an additional capital cost that we hadn't initially factored in. And getting the UV devices installed was really challenging. The HEPA filter devices, we could just plug them in. The UV ones had to be done during school holidays. We had to really plan for them. Space in school classrooms is a premium. They are cramped environments. Fitting stuff in, whether it's in the ceiling, whether it's on a portable thing, is hard work. And I say we hit a legislation framework issue. And from a motivation perspective, how do people actually do this? We rely on the teachers to deliver our study day to day. We rely on them to put the units on, we rely on them to make sure we've got the data on absences. They've got far more things to think about, to be quite honest. They are far more worried about the progress of their children, the fact that some of them are actually having to act as social workers as well as teachers. Ventilation was really low down on their list. Some of them, particularly the installed upper air UV devices, were too noisy. Not the passive ones, the active ones, far too noisy, so they would switch them off. And then janitors in the schools also have lots of demands on their time. They don't really switch stuff on. So there's a real behavioural issue with making this happen. And that lack of motivation, they voted with the off switch on many of them. They were noisy, they were hot, they were expensive, some of these devices. So that's not going to necessarily be true for 5UV, but it is something we really have to think about. You know, we think this might be a good idea. People who are receiving it might necessarily not. So engaging with these schools is really hard work. 31 schools, that requires a full-time person to engage with them. Even just keeping things on board We have to think about how we get that data, and we have to think about how can we make this as easy as possible for an environment to engage with. So I'm not necessarily saying we should all go out and do a school study, but I'm saying if we are going to do school studies or similar, we really need to think quite carefully about how we engage with those environments to make it happen. So just to finish up, what we've learned, we need this data. We're not going to progress to the point of being able to really make a difference with these technologies if we don't have the data that shows that clinical endpoint that they reduce infections. And we also lack the data that shows the real world factors around harms and even the practicalities. We've heard not a great deal about practicalities, but it is something that is really important to happen. We have to do some of these studies. We have to design them. They're really challenging. I think the things we've learned, we ought to have brought in our stats and FP expertise right at the beginning. We brought it in a little bit too late, and we were always playing catch up. We have to bring in a collaboration that is truly equal across all the different parts of it. It takes time. These studies don't happen quickly, and if you rush them, they will give you a poor answer. So you have to have the right time, size of study, right resources to do it well. There is no point doing a rubbish study, and we have to engage properly with the study sites. And I will leave you with this lovely picture that was drawn from the study site. Our schools were all part of a major UK cohort study called Born in Bradford, and all of the data and everything's connected through those, and all the lovely photos of your children all came from the Born in Bradford cohort study. So thank you very much.
Thank you for that. That was great and inspirational, I think. We have time for a few questions.
Thank you, that was fascinating. For those of you who haven't met me, I'm Lou Regard with NIOSH. So I've spent the past 18 months, in effect, trying to get funding in the United States, both inside and outside government, for clinical trials just like the ones you described. I agree with everything you said. They're extremely complicated. I just want to make a couple of points. One is that you alluded to is the importance of doing these studies in a way that collects both engineering data and human health data, because for a bunch of reasons. One type of data is often collected, but not the other, which is complicated, which Shelley alluded to in an earlier session. And these studies are very expensive. In U.S. dollars, we estimate that they're 20 to 30 million to do them well. So that's one of the reasons why I've been unsuccessful as yet, but I promise to keep trying. And I would just want to congratulate you, despite the challenges you have. Please think about it.
Thank you. Yes, and I totally agree. They are really expensive to do these well, and I don't think the study we did was as good as it could have been. It was as good as it could have been with the resources that were available to us at the time. But actually the pandemic played into this, because there were things that we could rush through that you would have not normally been able to do as quickly as well.
Okay, one last question.
Actually, there are two questions. So the first thing is, when I think about disinfection, I see filling the pathogens and removing them. And the mean of transferring this disinfection is different. So there should be a weighting factor how much each of these are efficient. So it's some sort of comment on the invention means you were actually proposing. The other thing is, as an engineer, when I think about the disinfection and a technical procedure, I see input, process, and output. So why should we go and put our output on people? Like, why we don't go from mouse to mouse? Like, inhalation to exhalation instead of like involving people.
So yeah, you're right, there are studies which do that as well. There are studies which are hamster to hamster or mouse to mouse. They, I think, tell us a great deal. They certainly tell us about some of the transmission routes, but there is that question about whether a mouse sneezes or coughs in the same way that a human does. So I think it's a really good, valuable data set, but it doesn't give us everything we need. And then, of course, if you go to larger animals, like non-human primates, they are very challenging studies to do from an ethics and research license perspective. And rightly so, you have to be absolutely on the nail with why you're doing that study to justify why you're going to use any animal, but particularly when you go to non-human primates.
Pardon my English, but like I meant mouse. Like
Oh, yeah.
Exhalation.
Oh, for
of human
people.
being, yeah.
Yeah, people.
The inhalation, because like that could be the input, and you have the process and the output, which is like another human being.
So human challenge studies, yeah, and they again are, but they are also hard because again the ethics of deliberately infecting people is different to the ethics of putting something in an environment where infection is already happening, and that's again a challenge. But yes. Okay.
Thank you so much.